Good morning, and thank you for the opportunity to present my research today. The views expressed in this presentation are my own. I have no disclosures. There are an estimated 1,500 individuals who sustain combat-related amputations in the United States Armed Forces as a result of the global war on terror. Depicted on the right is the Center for the Intrepid, a state-of-the-art rehabilitation facility that was opened on Fort Sam Houston in 2005. The mission for the Center for the Intrepid is to provide interdisciplinary rehabilitation for Operation Iraqi Freedom and Operation Enduring Freedom casualties who have sustained amputation, burns, or functional limb loss. Proper rehabilitation of these veterans have become increasingly important as survival from combat-related injuries, to include amputations, has increased dramatically since the beginning of the start of the global war on terror. With increasing rates of survival, attention should now be turned towards long-term outcomes for these patients. Several studies have shown that wounded veterans from the global war on terror have been noted to have increased rates of hypertension, diabetes, coronary artery disease, and chronic kidney disease. Subsequent retrospective studies have demonstrated that with this increased risk of cardiovascular disease comes an increased risk of mortality versus age-matched controls. However, there is no current data regarding long-term outcomes and survival of young adults who become amputees from combat. Historical data suggests that there is a high rate of obesity in the amputee population. Several small retrospective studies from the Iraq-Iran War of the 1980s and Vietnam War have shown obesity rates ranging from 17 to 82%. Such a wide range suggests that the true rate of obesity remains unknown. Associations between amputation, obesity, and the development of comorbid conditions also remains unknown. However, identification of a possible association between amputation and obesity plus associated comorbidities may help to better guide intervention for the obese in this particular population. Therefore, the objective of our study was to establish the prevalence of obesity and comorbid conditions in individuals having sustained a combat-related amputation in the United States Armed Forces during the global war on terror. Our study was a retrospective chart review of the Department of Defense Trauma Registry. All surviving patients with a combat-related amputation from the years 2001 to 2015 were included in the study. Individuals who died within the first 3 months following injury were excluded. The data collected included patient demographics, length of follow-up, number and level of amputations, pre- and post-injury BMI, pre- and post-injury comorbidities to include diabetes, hypertension, hyperlipidemia, obstructive sleep apnea, chronic kidney disease, major depressive disorder, and post-traumatic stress disorder. Lastly, pre- and post-injury functional status were obtained. Importantly, we would like to point out that post-injury BMIs were collected as corrected and uncorrected values. Corrected values were obtained using the pictured BMI calculator, which corrects a person's BMI based on the level of the amputation. A total of 1,214 charts were reviewed with 964 patients included for analysis. The average age of injury was 25 years. The mean length of follow-up was 7.8 years. The average BMI pre-injury was found to be 26.2 kilograms per meter squared, while the average current corrected BMI was found to be 30.8 kilograms per meter squared. In terms of the overall prevalence of obesity, we found that there was an overall increase in obesity across all age groups when compared to pre-injury values. This is depicted in the graphs by the blue bars, which clearly show an increase in prevalence from pre-injury on the left to post-injury on the right. We then compared the prevalence of obesity for the patients in our study to the national averages as reported by the CDC. The national averages are depicted by the red bars. As you can see, the prevalence of obesity in the general population is actually greater than the prevalence in our pre-injury subgroup. However, following amputation, the prevalence of obesity is significantly greater in the amputee population than in the general population across all age groups. We then stratified our data based on age and amputation site. Here you can see that those with lower extremity amputations had a higher prevalence of obesity across all age groups when compared to upper extremity amputations. The orange bar on the right illustrates the national prevalence for obesity based on CDC data. Again, you can see that generally across all age groups, those that sustain combat-related amputations have a higher prevalence of obesity, with the exception of young patients in the 20 to 34-year-old age group who sustain a distal or isolated upper extremity amputation. We then examined the prevalence of various comorbid conditions before and after injury. These first charts look at the prevalence of diabetes mellitus. As you can see from the graph on the left, none of the patients were diagnosed with diabetes prior to injury. Following injury, the prevalence of diabetes increases with age. Furthermore, you can see that compared to national averages, again depicted in red, the prevalence of diabetes was higher in our patients across all age groups. Similarly, with hypertension, there was an increasing prevalence of hyperlipidemia post-injury. Again, with national averages depicted in red, the prevalence of hyperlipidemia was higher in our patients across all age groups. When looking at the prevalence of hypertension, following injury, there is an increasing prevalence of hypertension that develops with age. However, the prevalence of hypertension in our patient population appears to be similar to that of the general population. Logistic regression models were utilized to determine risk factors for developing obesity. We found that if patients were overweight or obese prior to injury, they were 4 to 11 times more likely to be obese following injury. In terms of length of follow-up, those that were followed for 10 to 16 years were more likely to be obese. This suggests that the further the patient is from the time of injury, there is an increased likelihood that they will become obese. In looking at the location of amputation, those that underwent a transfemoral amputation were more likely to be obese. Those that underwent a transradial amputation were less likely to be obese. And interestingly, those that sustained a traumatic brain injury were less likely to be obese, though the reasons for this are unclear. We then utilized a subset of patients who were initially not obese prior to injury and subsequently found to be obese with a BMI greater than 30 after. Patients were stratified by amputation sites, and a Kaplan-Meier curve was generated, which can be seen here. The graph demonstrates that those with bilateral lower extremities have a higher probability of becoming obese within the first year when compared to those with unilateral lower extremity amputations or upper extremity amputations. Importantly, this graph clearly demonstrates our finding that in this subgroup that was not obese prior to injury and became obese, 50% of those patients become obese at about the 1-year mark following amputation. Additionally, we found that in patients with a BMI less than 30 prior to amputation, there's a 75% likelihood that they will remain non-obese at 2.5 years. So as you can see, at 2.5 years, the curve kind of levels off, suggesting that if patients are approximately 2.5 years from injury and are at a healthy weight, there's a high likelihood that they will not progress to obesity. These timelines become very important when considering appropriate surveillance and intervention following traumatic amputation. Our data suggests that patients who sustain combat-related amputation should undergo strict surveillance during the first year following amputation and will require close monitoring for up to 2.5 years following injury. In conclusion, there is a notable prevalence of obesity that develops in the amputee population that's much higher than the general population. The amputee population appears to be at risk, and these patients should be monitored closely for the first year to 2.5 years. Creation of a policy for weight monitoring for those found to be trending towards obesity could make a significant difference in long-term outcomes for these patients. In the future, further study of this at-risk population may provide insight into the disease of obesity for the general population. Mahalo nui loa for your time and attention. Are there any questions at this time?